Now, after covering the history, examination, and how to assess the brachial plexus injury and generalized principles of the management, and we have briefly gone through the generalized principles of management in herbs, calamities, palsy. We will be briefly going to the specific nerve syndromes which may be involved. For example, if suprascapular nerve is involved, or if the nerve, long thoracic nerve of the bell is involved, or if there is injury to access the scapular nerve. We will be briefly going through the different type of nerves, how they may be injured, and where they can be injured, and what type of clinical presentation occurs when they are injured. So, coming to the brachial neuritis, this is a very rare form of infection of the nerve system, usually following post-viral syndromes. That is, viral infection. This results in a formation of a post-viral infection. This leads to brachial neuritis. This is an inflammatory condition of unknown pathology or etiology that affects the upper portion of the brachial plexus, and mainly the upper portion is usually infected. This results in neurological pain and muscle weakness, usually precedes a viral infection or stress. The small diameter nerves are affected, especially the suprascapular nerve, which is supplying the supraspinatus and infraspinatus muscle, and neurologic amyotrophy usually may be associated with this brachial neuritis. Electromyography can be specific for diagnosis because EMGs would reveal muscle fasciculation, sharp waves in supraspinatus and infraspinatus only. And NCS may also help us because they will usually not show any definitive cut-off lesion in the nerve conduction studies. Coming to the injury of long thoracic nerve, as it is also called as nerve of Bell and supplies the serratus anterior muscle. It starts with from upper area from C5, C6 and C7, and it takes out its from the ventral rami before the trunks are actually formed. It can be damaged during surgery, that is head and neck surgery such as sympathectomy or mastectomy. These surgeries where during other head and neck procedures, this may get damaged. Once it gets damaged, it's actually supplying the serratus anterior muscle. Therefore, serratus anterior is actually attached on the scapula laterally, such a way that once if it gets damaged, this results in the medial winging of the scapula. This may lead to paralysis of serratus anterior, aches and weakness. Fulcrum supraspinatus and infraspinatus is unstable, and unopposed pull of the trapezius and rhomboids on the clavicle on the scapula will cause the medial winging of the scapula. Treatment: usually if it's neuropraxia, that would recover in 3 months time. This is called a spontaneous recovery. Otherwise, we may have to do some kind of operative stabilization. If it's more than 6 months, then the option include transferring the pec major or minor to the lower part of the scapula. That is actually to restore the unopposed pull of the trapezius rhomboid, and therefore the reversal of the medial winging of the scapula. Other option, if the muscle transfer is not possible as well, or if it has failed, then we can go for scapulothoracic fusion so that the medial winging of the scapula can be prevented. Coming to the spinal accessory nerve, this is a nerve which actually supplies the sternocleidomastoid, the muscle in the neck, as well as the trapezius muscle. It invades the upper half of the trapezius. It may be injured in the stab wound, especially stab wound to the neck. This may get injured there. Or sometimes when the lymph node biopsy is done in case of for the tuberculosis or for the diagnosis of lymphoma in the neck, this may be an iatrogenic injury leading to spinal accessory nerve paralysis. Other causes could include whiplash injury and which may lead to aching of the neck and these discomfort. Clinical features, as you know, it supplies the trapezius as well. Therefore, once the medial tug is actually paralyzed, the trapezius rhomboid is paralyzed, serratus anterior pulls it laterally, leading to lateral winging of the scapula. Poorly localizing pain in the neck region could be one of the causes. Restricted shoulder movements. There will be dropping of the shoulder as the trapezius is actually helpful in the shoulder movements as well. There may be weak abduction. There may be a lateral winging of scapula and reduced trapezius mass, because once the muscle is not supplied with the nerve, it actually results in atrophy. Treatment: one option is if it's actually acutely injured and iatrogenic injury, we can directly repair it. But other option, if it was a stab wound or gunshot or some other form of injury which has resulted in a spinal accessory nerve injury, then the option could be at 3 months to 6 months we can go for nerve grafting or transfer of levator scapulae rhomboids to the scapular spine, so that this unopposed pole of serratus anteriorly encountered in this lateral wing of the scapula can be prevented. And coming to suprascapular nerve, it arises from the upper trunk of the brachial plexus. Usually, it supplies the supraspinatus and infraspinatus muscle. This results in pain if it's damaged. This results in pain in the suprascapular region. There is a weakness of shoulder abduction because supraspinatus is involved in the initiation of abduction till 15 to 20 degrees. And once 20 degrees, beyond 20 degrees, the actual deltoid takes up the function of the abduction, and then it carries out till 120 degrees of abduction. Wasting of maybe associated wasting of supraspinatus and infraspinatus, and usually the treatment involves if it gets entrapped between the suprascapular ligament, which is just like this one. If it's problematic over there, then we can do the division of the suprascapular ligament, or if it is damaged due to some other reason, then we may need to repair the nerve as well. Other options include the distal transfer of spinal accessory nerve to the suprascapular nerve, so that the nerve transfer can be done as well, so the functional effect of the supraspinatus can be restored. Coming to the axillary nerve, although axillary nerve arises from the posterior cord of the brachial plexus, that is C6, C7 mainly, it runs along the subscapularis, descends down, and then enters from the quadrangular space back into the axilla and runs all the way up to the deltoid and gives off the supply to supply the teres minor and deltoid both. It emerges behind humerus and from the quadrangular space along with the posterior circumference femoral artery, and once it gives a medial and anterior branch. Now this medial branch will go towards teres minor and anterior branch will come upwards and give it a branch to deltoid as well as superficial cutaneous branch. This may be injured during shoulder dislocation, especially during the anterior dislocation of the shoulder, it can get damaged. Clinical features usually results in paralysis of deltoid. And as the deltoid is the main muscle bulk which forms the shoulder contour, this results in shoulder weakness and deltoid gets wasted. Abduction cannot be maintained because if the supraspinatus starts the abduction till 20 degrees, from 20 degrees onward, it's taken up by the deltoids, and then deltoids takes all the way from 20 degrees till 120 degrees of abduction is being done by the deltoid. If the deltoid is wasted, this cannot be achieved. Therefore, the abduction can be started but cannot be maintained. Usually, it may be associated with shoulder dislocation. There could be injury to the rotator cuff or suprascapular nerve as well. Rotator cuff muscle includes supraspinatus, infraspinatus, teres minors, and subscapularis muscles as well. In high velocity injuries, all of this rotator cuff tear along with the axillary nerve injury can happen as well. Treatment is deltopectoral approach or posterior approach can be used, and if this results, maybe grafting and nerve transfer can be done so that the function of the axillary nerve is restored. But if it's beyond 6 months, then we may need to do the muscle transfer so that the functional aspect of the deltoid can be restored. In this section, we have briefly gone through the different upper brachial plexus injuries such as involving the C5, C6, and C7 nerve roots. We have briefly discussed what happens when the long thoracic nerve of belly is injured. This results in paralysis of the serratus anterior and medial winging of scapula. We have briefly discussed that what happens if the spinal accessory nerve is injured. This leads to paralysis of rhomboids and trapezius, leading to lateral scapular winging. And if its axillary nerve is damaged as it exists through the quadrangular space below the subscapularis muscle, this can lead to paralysis of the deltoid, and the abduction of the shoulder joint can be severely affected. Thank you very much. Keep watching sqadia.com.